possibly even, in a sense, we will self-insure. In other words, we will have a private contract with one large insurance company to underwrite the Scripps Health system. So we would offer to the public the Scripps Health Plan, which is an integrated medical plan along the lines I've mentioned. Now, since I'm a physician, I think I can best speak to the challenge of the doctors in this new partnership. And I challenge some of you from other countries to look to see if this model would even be applicable to your own country. And even a challenge to the public hospital administrators to see if some of the principles here apply to your planning of health care even within your government-funded public system. Now, in the next slide, we see what the challenge is for the physicians. We need, and as we speak, this is going on today. This has been a phenomenon of the past 6 months. We're charged with creating a model and structure for Scripps Health Medical Group and for negotiating the final details of the 50-50 partnership. We have to have models that will maintain the integrity of current medical groups. We have to look at the geography of San Diego and see how to best deploy the physicians and care facilities. We have to look closely at this primary care specialty relationship, try to incorporate the necessary subspecialty physicians that we'll need. We've got pediatric ophthalmologic plastic surgeons who, if your 10-year-old has a tumor behind his right eye, we're fortunate we have super subspecialists that know how to handle that problem. How do we incorporate them into the system? We most importantly need an extensive information support system for the entire healthcare system. This is where many hospitals are lacking. Ours, I am sorry to say, is behind in information systems, but our new administrators, a group from a company called Professional Health Consulting Group, Dr. Stan Papelbaum and Cyril Turner, in conjunction with our new CEO of Scripps Health Physicians. These men are providing strong leadership to go forward with this coalition, but only if the organization is committed to an extensive expenditure in information systems that will allow the connectivity between the outpatient, inpatient facilities, between every one of the doctors. This is key for delivering efficient, cost-effective care, and this system will fail without an attention to information systems. The next slide shows the old type of information system where we thought we needed computers just to keep track of the money, the finances, the patient accounting, whereas the outpatient clinical needs, hospital records or inpatient hospital records, well, that was important, but computers were for the money. However, in the next slide or plate, you will see the emphasis of information systems in the new model that we propose, namely that the connectivity of the patients with their physicians is primary. That's where the money will be spent. Now, in looking at our community and trying to decide how many physicians we need, we look at models such as in the next figure from Richard Chronic in the New England Journal of Medicine, where you can see that for a patient base of 300,000, a certain number of specialists and primary care physicians are needed. And if we translate that in the next figure to San Diego County, now looking at ratios of 100,000, it's estimated that we need about 140 doctors per 100,000 lives. Remember, we have 2.5 million lives in a rather confined area. The actual number of physicians in San Diego, unfortunately, exceeds the need under the new system by a considerable number. We have 6,000 doctors and over 2,000 in excess. Now, they're not out playing golf every day when they don't have enough business. It does appear that everyone seems to be working, but in the new cost-effective integrated system, we just frankly are not going to need large numbers of subspecialists, and in some way their careers will have to be readjusted, they'll have to move or whatever in order to deliver a capitated system that will be cost-effective and competitive with Kaiser, with Sharp Healthcare, and other care providers in our community. As I mentioned, the planning process for this new healthcare enterprise is underway, and I show you a rather complex diagram that I want you to study extensively on your own that shows on the left-hand side the more primary type of care, rising on the right-hand side to the highest, most complex type of care, which is more costly, with the dotted line indicating the volume of services in such an enterprise. Notice that the preventative and primary services are of the highest volume, the lowest cost, but most physician-intensive. Whereas on the upper right-hand side, we have the high-tech transplants, trauma care that require tertiary and higher-level institutions. And our key then is to integrate all of these types of care into an entire system, the bottom line of which is to redistribute the health care premium dollar. The next slide shows that currently HMO or management companies take 25 to 32% of the health care dollar. In other words, administrative costs are taking away from patients at least 20% of what could be reverted to actual care costs, so that hopefully under our new system, by streamlining that aspect, we will reach an optimal system where 91% of the care dollar goes to actual care. Well, let's look to see if other countries are adapting to similar pressures. In Canada, for example, a 1995 goal was to reduce acute care beds by 20%, decrease length of stay by 20%, substitute continuing long-term care for acute care, and reduce the variations in rates for surgical procedures and the shift of surgery to outpatient facilities, similar to the U.S. And it was thought that it was possible to rearrange facilities into a new population-wide system. This system is seen in the next slide, and you notice that the various type of components that are required are quite similar to what I have discussed for the U.S., in contrast to their older, more segmented system. We naturally wish them well and hope that some of the principles I've outlined today are applicable to Canada. In order to have these changes, this radical transformation occur, I believe that we must have a complete change in our cultural attitudes and actions. And I'd like to finish by reviewing two figures that emphasize the personal change that we all must go through in order to think in a transformational process. Instead of maintaining the status quo, we've got to think change. In exchange for the alleged stability and the certainty of our current practices or principles, we've got to be willing to have uncertainty and instability for a while. Instead of feeling secure as administrators who think they have a fixed job and a designated slot, we need leaders that will transform this care. We need coherent strategies, not just random tactics of care. Instead of disconnected systems, we've got to have integrated systems. Instead of basing our care on transactions, in other words, so many gallbladders removed, so many psychiatric admissions, we have to think of population-based reimbursement. That means we look at the population, the 2.5 million of San Diego, the 90 million in Mexico, wherever, and we create our system based on the percentage of resources of various types that should be applied to that population. Instead of building more hospital beds with bricks and mortar, we think in terms of managing lives, not hospital admissions. We think of information systems and networks of doctors. So, in addition, instead of individual action, we doctors and administrators have to get together for group action. We're all on an equal footing. Whereas before the public took the risk of supplying the money for care, we have to assume the risk. We have to tell the public that we can give them such and such for so much money and take the risk if we can't. Instead of doing this slowly, we've got to be bold. Instead of just using consensus of what everyone feels now to direct, we've got to first set the direction. We've got to be brave and bold and then build the consensus around the direction, obviously as long as it is correct. And for the rewards in this system should not be for maintaining the status quo, but only for contributing transformational behavior. Now this is radical, but it gives me a bit of hope as a physician approaching the year 2000. It's been a great pleasure for me to be with you today. Like many physicians, I've been frustrated by some of these trends in health care that make it harder for the patient to get care, harder for me to deliver care at a reasonable price, and harder for me to personally gain economic security that once seemed inevitable in the old system. However, we have discussed some of these refreshing changes that are emerging that are going to give physicians more control over a major portion of healthcare planning. And as our board chairman says, there's just two major pieces to healthcare: the patients and the doctors. We have to do what we must to bring them together. This same principle and many of the things that I've discussed today, I believe are applicable to private as well as public sectors in other areas of Latin America that are largely composed of health systems funded by the government. I hope that some of these same principles of involving your physicians in the planning and the care delivery will occur. And in fact, the trends that we see in Mexico, where instead of the public sector building or reduplicating things that the private sector has built, to subcontract, to use the private sector in a partnership for delivery of care. That's the whole idea. All of us providers getting together wherever our source of money to go directly to the patient with an integrated plan. Thank you.
Thank you, Dr. Nelson. Let us continue with the second question and answer session. We have a question from Argentina, from the Consejo de Médicos de la Provincia de Córdoba. Welcome. Your question, please.
Yes. Regarding the model for managed care, according to what we have heard, efficiency and equality are premises that only 50% of the population can access and does not apply to all citizens. How do you think you can solve this only with the healthcare agencies, and what role would the nation, the state, play in this situation? Thank you.
Well, that's a very tough question. I'm not sure I can answer well. But I think in terms of what you heard in Module 2 here, about even our new emerging healthcare system that we're going to try to develop, the state planners and state funders and those that are responsible for delivering care to, let's say, the traditional state-supported percentage of the population, they're just going to come to the table with us. We're just going to have to work together so that whatever healthcare system we end up with smoothly integrates them. Now, it's hard to just say in a broad, sweeping way. But I guess the key is that sector will not be sitting out there in the cold by themselves. We're going to make an effort to get closer and closer than we ever have before to, integrate our system of care in a given community.
We have a question now from Coahuila, from the Universidad Tecnológica de Coahuila in Ramos Arizpe, Mexico. Welcome. Your question, please.
Yes, thank you. During the first question and answer session, you mentioned that the population should be very careful and tolerant regarding the claims for malpractice due to the fact that doctors and hospitals are trying to perform their work as best as possible. This is the only mention of quality care you've made. How do you account for the results for quality care from doctors and hospitals, given the fact that a mistake could account for a human life?
It's very good that you brought up that question, because in our healthcare delivery model that we talked about and the evolution of managed care, I did not get time to address the matter of looking at the product. So the whole thrust or movement that we call quality assurance is absolutely a key component to all of our healthcare delivery. I should have put a slide about that, but you could add to everything I said that there will be a system of administrators and physicians looking at the quality of the product of care. Every hospital admission is reviewed. The criteria for bringing someone into a hospital is reviewed. The actual outcome is reviewed. We talked about gallbladder operations. I can assure you that our committee will make sure that the outcome in terms of comfort and success of gallbladder operations is looked at closely, every chart. So we'll be constantly focusing on the quality of our product as the patient comes out of the production line, so to speak. We can't just give care and hope it's good. We will prove that it's good, and if it isn't good, we will then change the method. Very good question.
We go back to Panama now, the Universidad Tecnológica de Panama. Welcome. Your question, please.
A country that thinks of establishing a system of service providers, in your experience, to pay the provider, what would be the most fair system that would protect the poor in services, poor or damaging interests, the per capita system or a more democratic system?
Well, it's thought that the per capita system is fairer, as you put it, or at least easier to manage for, let's say, maybe for everyone. You certainly, if you're paying for it, you know what the cost is in advance. As I said earlier in the program, I guess I grew up at a time when I liked the old method where I could charge $100 for whatever, and I knew $100 would come in. But perhaps someone out there didn't have $100. The capitation method will allow an employer with, say, 100 employees to know that if he has to pay $12 a month to a health care system for his employee to get all of his care, everyone will get care, and we know what it costs in advance. So there is seemingly a great advantage for the capitation method in some sectors of society. So I think that we'll have to test it, but we're hoping that the quality, particularly for the persons who could not afford care before, is delivered better with this new system.
We have a call now from Cuautitlan, from UNAM, the Facultad de Estudios Superiores in Cuautitlan. Welcome. Your question, please.
Why, instead of confronting or actually talking about the medical costs, businesses and governments do not promote the compulsory practice of exercise among workers, since there is proof that exercising reduces the visits to the doctor?
Right. I know we sound here like an economist, and I want to remind you that I'm a doctor. I'm interested in delivering the care. Actually, the economics is a rather dry topic. You're absolutely right. As part of the preventative portion of medical care that I talked about, you could imagine that a healthcare system would infiltrate the workplace. We would go to the employer of 100 workers and help him devise a preventative exercise strategy, have classes on nutrition, prenatal care, proper immunizations for their children. I can see that the healthcare systems will infiltrate society to a degree that we don't have it now, and this will be a very good thing. So your exercise program will be crucial to any healthcare delivery system that I'm interested in.
And now a question from Lima, Peru, from the Universidad Nacional de Ingeniería. Welcome. Your question, please.
The question has to do with the new model that you're working with regarding several indicators, quality indicators. For example, you've worked for a long time with the system of accreditation of services. But with these changes, you're changing the quality indicators as in terms of output or outcomes, and change it to some indicators, for example, in this case. And the other question has to do with the information that the users receive in order to be able to choose between the different plans. Who is the person in charge to provide that information? Is this the state? Is it private entities? Or mixed or joint entities?
I think the last one's the easiest. I'm sure the various health plans will have their marketing departments and brochures and informational materials that will allow the public to make the best choice of a health plan. We naturally are hoping those dollars will be small, but you're right. It's going to take constant education of the public so that they know what they're getting. So that, I think, is a straightforward marketing problem. In regards to your indicator system, that's a complex question, but basically I think you asked, how do we use indicators now of outcome in planning? Well, for an example, we decide, regarding our gallbladder operation we talked about, that 95% of patients with the gallbladder procedure must be out of the hospital in 24 hours. Now, if we suddenly see that the statistics show that 80% of people are leaving in 24, but for some reason 20% are staying 2 days, something's wrong. We know now the doctors can do a gallbladder with a laparoscope and the patient practically goes home from the operating room. So using that indicator, which is like a red flag, the indicator changing from 5% to 20%, we use that now to help us uncover problems with the particular procedure or particular illness as to how we're managing it. So it sounds rather dry and boring to think of indicators, but let's say it's a discovery mechanism of error.
Thank you for your excellent questions, but we have run out of even our extended time today. Thank you, Dr. Nelson.
Thank you for sharing with us, and we look forward to comments even in writing from you.
We hope that you have enjoyed participating in this video conference. We will continue transmitting programs on the latest in management systems techniques and global competitiveness. We invite you to participate on May 8th in the next program of our series entitled The Global Leadership Challenge, Change and Accountability. For additional information on the International Training Center's programs for this year, please consult your participants' manuals, where you will find the dates and specific topics for these. Also, if you are interested in participating in training programs which will be offered by the International Training Center, such as those on ISO 14000 and International Business and Telecommunications, please contact the Center by letter, phone, or fax. On behalf of all of us who collaborate with the International Training Center, I thank you for your participation and interest in today's program. Thank you, and see you soon.